Hello, friends. We are back again with a new case. Let us start. An 8-year-old girl presented with swollen right joint with migratory pain from one joint to another over a period of hours. She had an abnormal gait. On examination, painless small mobile lumps under the skin overlying the bony prominence of hands, feet, and elbows were found. Her mama was heard over mitral valve area. ECG showed prolonged PR interval. She had an episode of sore throat 3 weeks back. So, what is the most likely diagnosis? What is the most common causative agent? Pathogenesis, investigation, treatment, and prevention. So, any guesses? I will give you some time to think over it. So, yes, you have guessed it right. It is acute rheumatic fever caused by Streptococcus pyogenes, usually the serotype 1, 3, 5, 6, 14, 18, 19, 24, 27, and 29. If you cannot remember the serotype, it is okay. But you have to remember Streptococcus pyogenes as a causative agent of acute rheumatic fever. It is basically an immunologically mediated complication which follows this bacterial infection. So let us see its pathogenesis in detail. So usually untreated streptococcal pathogens pharyngitis, that is sore throat, in 3% cases, not all cases, only 3% cases, in usually children of 5 to 14 years, because it is rare about 30 years. So even more than 15 years, it is less common. So usually children of 5 to 14 years in 3% of cases of untreated cases, yeah, this is usually seen. And obviously here the antibodies which are formed, that is anti-streptococcal antibodies, they shows autoimmune cross reactions with antigens of joints and heart tissues. So 1 to 5 weeks after pharyngitis, they develop inflammation of these tissues like mitral valve, joint synovial fluid, skin, and brain vasculature. So this causes arthritis, that is joint inflammation, pancreatitis, that is inflammation of heart layers, subcutaneous monodules, and erythema marginatum, that is nodules in subcutaneous tissue, and skin redness, that is erythema marginatum. And it causes involuntary movement in form of sit-and-hum chorea. So these are the five major manifestations of this condition. And most manifestations, they resolve completely except the cardiac ones. And permanent endocardial damage can happen, and which may present murmur even after a few years. So that is the detailed pathogenesis of this condition. Actually, DR7 and DR4, these individuals, they are more susceptible to this condition. So there is some genetic element also involved in this. So what are the investigation and how you would diagnose this? So for this, we are using a criteria known as modified Jones criteria, uh, as per 2015. So there are two things. There are major criteria and minor criteria. If you have two major or one major plus two minor, then it is initial acute rheumatic fever. If you have two major or one major plus two minor and three minor, then it could be recurrent ARF with a reliable history of ARF or RHD previously. So uh, this you have to keep in mind to diagnose it. So either you require two major or one major plus two minor or three minor. So अगर आपको major, if you want major criteria, two are needed. If one major is there, you need at least two minor. Or if you diagnose with three minor criteria, then that is only possible for recurrent ARF. Now let us see major criteria. It is very simple to remember the five major manifestation. That is carditis. It could be clinical, it could be subclinical. The Sydenham chorea, the erythema marginatum, the subcutaneous nodules, arthritis, that is polyarthritis, and usually it is migratory. But it can involve single joint monoarthritis in high risk population and polyarthralgia. Now, these two terms are different. This is inflammation and this is pain. So, polyarthralgia, that is pain in multiple joint in high risk population, or inflammation of even a single joint in high risk population is considered as major criteria. So, what are the minor criteria? So, polyarthralgia in low risk. So, patient population is low risk, but having pain in multiple joints, or single joint pain in high risk population, that is minor criteria. Hyperpyrexia, that is temperature of more than 38 degrees centigrade. ESR 60, it could be 30 in high risk population, millimeter per hour or more. Or you can do CRP level, that is 3 milligram per deciliter or more, and prolonged PR interval. So these are minor criteria. So if you have two of this, then it is ARF, initial as well as recurrent. Or you can have one from this and two from this, then it is sufficient to diagnose initial as well as recurrent ARF. And for recurrent ARF, even any three of this is present with previous reliable history of ARF or rheumatic heart disease, then again it is sufficient to diagnose recurrent ARF. So I hope these criteria are very clear. How I remember is based on the mnemonic Jones, that is J stands for joint, that is arthritis. Oh, I remember as heart shape. You know, heart shape, that is so carditis. N stands for nodules, so subcutaneous nodules. E stands for erythema marginator. My S stands for Sydenham chorea. So that's how I remember this. I hope that helps you to remember the major criteria. Now, what should we do for treatment? So, treatment first, we will treat the acute episode. So, in acute episode, the antibiotics are needed. That is per oral penicillin V and amoxicillin for 10 days. So if a person is suffering from sore throat, then give this antibiotic, either penicillin or amoxicillin for 10 days. You can even give aspirin for arthritis, arthralgia, and fever. So supportive or symptomatic treatment. And what we can do for prevention. So for primary prevention, we will treat this group A streptococcal upper respiratory tract infection or sore throat with antibiotics within 9 days of onset. For secondary prevention, if patient has one episode of rheumatic fever and they are given long-term antibiotics, that is parolar, penicillin V or erythromycin to prevent cardiac damage, because cardiac damage is permanent. Rest of the things will resolve spontaneously. Now, for how long you should give this penicillin or erythromycin orally to prevent this cardiac damage, that depends on the condition. A person has not developed carditis, that means ERF is there without carditis, then you can give it for 5 years or till age of 21 years, whichever is longer. If person is having carditis but there is no residual heart disease, then give it for 10 years or 21 years of age, whichever is longer. If person is having carditis and residual heart disease, then for 10 years or till age 40 year, whichever is longer. And sometimes lifelong antibiotics are required. So this is very important for management perspective. So that's why we fear the group A streptococcal sore throat, because sore throat is not the problem. Problem is its immediate as well as long-term complication in form of glomerulonephritis as well as acute rheumatic fever. And acute rheumatic fever, the endocardial damage causing carditis and residual heart disease is very dangerous. So I hope you learned this topic very well. This is very frequently tested on various examination. And do subscribe to the channel for regular updates on such kind of videos. Thanks.